Welcome back to Oncology for the Inquisitive Mind, where Michael and I are about to do a marathon recording session. Josh forgot the cord, so it's taken half an hour for us to get to this point. So, Michael, great to see you. Thank you, as always, for your patience. How are you?
I'm good, Josh. I appreciate you giving our listeners that little peek behind the curtain there. But yeah, a continuation of our Back to Basics series. And we are slowly, like the orbit of the planets around the sun, we are slowly coming to the end of our extravaganza on prostate cancer. But we've got an exciting show for you. We hope you're as excited as we are.
Let's jump right into what we're talking about, which is the evolution of Theranostics, or specifically radioactive ligand directed therapy against cancer, and in this case, prostate cancer. So without further ado, Michael Fernando with those baby brown eyes, let's get started.
Yeah, so when Josh talks about Theranostics, the main thing at the moment that he's referring to is Lutetium-PSMA. Now, Josh spoke last week, I think it was, about radium-223, which is probably a primogenitor of what we're doing. But Lutetium-PSMA is a much more targeted form of theranostic therapy. It is a radioactive molecule that is attached to a PSMA vector that gives the treatment some selectiveness, I guess, for prostate tissue. And so rather than just injecting radiation or radioactive materials willy-nilly, which, as we said last week, Marie Curie found was not the best way to maintain your health, the attachment of lutetium to a PSMA vector actually enables it to have a therapeutic benefit. And as Josh will say in his studies, this has shown some evidence of benefit in the castration-resistant phase, usually after patients have had significant number of rounds of treatment. You're starting to reach for your cabazitaxels and your best supportive cares at that stage, but it is really starting to take off in centres that have access to it now. Access is the operative word here, because to manufacture the lutetium and the PSMA, must confess, Josh, I have no idea how it's actually manufactured. I just know that it is very expensive and only available in a select few centres. I think in Australia, certainly in Victoria, there's only one centre that does it. And so you can only get it, obviously, at this centre. Access is obviously an issue. And we've spoken previously about access to PSMA PETs and how they are far from ubiquitous in Australia, and you can expand that to around the world. So access to these novel therapies, as with any novel therapy, is an issue. However, where you can get it, it's being wholeheartedly embraced as one of the next big things. So previously, and Josh will go into this in a bit more detail, but lutetium PSMA has found a home, a niche in the castration-resistant space. The obvious question is it worth moving it forward to the hormone-sensitive space? Now, the UpFrontPSMA study is a phase 2 study that examines this very question, the addition of lutetium PSMA 617 to docetaxel for patients with metastatic hormone-sensitive prostate cancer. And I do want to mention this because it's exciting for me. Josh and I were actually in the room when this was presented at ESMO last year. So if you have listened to our ESMO 2024 extravaganza, doubtless this will be familiar ground, but it's always exciting for us to be in the room where it happened. The study enrolled 130 patients. Now, this is an interesting first point to make. And normally we sort of gloss over the number of patients that were enrolled, but I've been getting a bit into statistics, Josh. Some might say that makes me very boring and tedious at parties, but he's nodding sagely there. I think that predated my interest in statistics, but the study designs aimed for 140 patients to provide an 85% power to differentiate between the two arms, assuming undetectable PSA proportion at 48 weeks of 25% in the control arm and 50% in the experimental arm. So they took these assumptions and they have an 85% chance or an 85% ability to detect a difference between the two. The fact that they didn't quite make it to the assigned 140 patients, 130, did slightly reduce the power from 85 to 82%. Is it going to impact the validity of the results? Probably not, but it is something that is worth noting because it's not something that is frequently mentioned in these studies. For inclusion criteria, patients who are enrolled had to have de novo high volume metastatic hormone sensitive prostate cancer. They have to have received less than 4 weeks of ADT. So this is right at the start of their treatment. Their PSA had to be greater than 10 nanograms per milliliter at diagnosis. And they had to have a high tumor uptake and high volume disease on PET, which is important. Coming back to that question about access, in order to get on this study, you had to be at a center that had not only the lutetium PSMA, but just a PSMA PET scan. Makes perfect sense though, because if the PSMA is not visible on the PET scan, then it's unlikely that lutetium attached to PSMA is actually going to make it to the cancer. Patients were randomized to the experimental arm, which was the combination lutetium PSMA 2 rounds and docetaxel the usual 6 rounds. And the control arm was just docetaxel on its own. The primary endpoint, an interesting one, undetectable PSA at 48 weeks, which, any other tumor aside from maybe testicular cancer, you would really cop some flack for, but PSA is obviously a decent marker for prostate cancer. Secondary endpoints, PSA progression-free survival, the time to development of castration resistance, radiographic progression-free survival, overall survival, quality of life, and pain. It is worth highlighting their choice of primary endpoint. Josh, you've ragged on a couple of studies in the past about the choice of endpoints, and it is interesting that undetectable PSA at 48 weeks, while that seems to be almost the go for lutetium studies, because I think TheraP had a similar outcome. And I think Vision might have as well, but we'll come to Vision in a bit. It is interesting that they don't just do radiographic progression-free survival or, overall survival would always be nice, but patients with prostate cancer, especially treatment-naive prostate cancer, are living longer, so that makes it harder. In terms of notes of the demographics, so 6% of the investigation arm compared to 10% of the control arm had visceral disease. And the severity of disease, aggressiveness of disease, which is classified by grade groups. So patients had grade group 4 or 5 disease in 91% of cases. So this is a group of patients with aggressive disease. The median PSA at time of enrollment was 48 versus 31. Is that a huge difference? I don't think so. In terms of the primary endpoint, so the PSA undetectable rate at 48 weeks was 41 compared to 16%, with an odds ratio, not a hazard ratio, an odds ratio of 3.88, basically meaning that you were almost 4 times as likely to have an undetectable PSA at 48 weeks. And this was statistically significant. 17 compared to 18% of patients had an undetectable PSA at week 12, however, which is interesting because it suggests that the lutetium takes a bit of time before it starts to differentiate itself. You could almost think of it, if you're a visual learner like me, in terms of immunotherapy, Kaplan-Meier curves, how you have the start of the Kaplan-Meier curve where immunotherapy by itself is frequently inferior to chemotherapy control arms. So it is interesting that you have to get patients through those 12 weeks before the lutetium starts to pay off. In terms of secondary endpoints, these all benefited the lutetium arm. So hazard ratio for PSA progression-free survival 0.6, freedom for castration resistance also 0.6, the radiographic progression-free survival 0.58, and the overall survival, which is immature at this point, 0.83. If you look at the curves, there is a nice trend, I guess, towards an overall survival benefit. But again, this is right at the start of a cancer that has so many very effective therapies. So the overall survival data is going to take a long time to read out if indeed it does happen. In terms of safety, there were similar rates of grade 3 to 4 adverse events, 29 to 27%. You're always going to have a baseline number of or incidence of side effects when you're comparing a chemotherapy arm. The main exception that I could find was dry mouth, which was much more common in the lutetium arm, 37% grade 1 to 2 compared to 0% in the control arm. Thankfully, 0% grade 3 to 4 in both arms, because a grade 3 to 4 dry mouth seems like a form of medieval torture. In conclusion, to conclude UpFrontPSMA, it's a very interesting study and it's a natural progression of new promising treatments. When you have something that seems to work in a later phase, you're always going to want to push the envelope and push it forward. There is a suggestion of benefit with the addition of PSMA lutetium, but no overall survival benefit as yet. Now, a couple of issues that I have noted, and Josh, I would always be fascinated to get your thoughts on this. The complete absence of, we'd call them novel anti-androgens, but ASRIs. So probably due to the time course of when the evidence was published, but no patients had enzalutamide or abiraterone or darolutamide or apalutamide, all of the stuff that we've spent the past 3 months talking about. And that is very much now the standard of care in this population. Remember, majority of patients had high risk disease. You had to have high volume disease by the chartered definition to get onto the study in the first place. So if you weren't in a place that had lutetium, that had access to everything else, you would be looking at either doublet without chemo or a triplet if they're particularly fit. So that is the main thing that is missing from this picture. And I spoke about the access and availability, not just of the radioactive lutetium component, but of PSMA PETs, which were used as screening. In the future, where we're all riding holographic skateboards and, getting into fights with Biff Tannen over a betting book history, Josh is looking at me blankly.
I like to think that I do know the reference from Back to the Future. Also, I'm pretty sure Biff gets in a lot of trouble in real life down the track, so let's not talk about that.
When we all have access to lutetium PSMA is where I was going with that slight detour. This might be part of the puzzle, but for the vast majority of people, unfortunately, it's going to be something that is not available, I guess is my main takeaway. Good to have it if you can get it, but a lot of people won't.
Yeah, you're right. The standard of care here is probably a little bit nefarious or not what we do in practice, but also at the same time, that's the design issue of many of the trials, not just prostate cancer, but most other cancers that we are grappling with until things come off patent. So there's not really an easy solution. I think potentially for those who can't tolerate or those who don't want it, it's an option. It's hard. It's a very evolving space and it's a very fast evolving space. Would you like me to chat about my studies, Mikey?
Please do.
I'm going to change my tact a little bit. You have a patient who has metastatic castrate-resistant prostate cancer. They've burned through the standard of care therapies, enzalutamide or abiraterone or apalutamide or darolutamide. I don't want to favor anyone. So an RC or an RP, depending whichever way you want to talk about in the hormone sensitive space. You've given them docetaxel. They got a couple of years out of that. They've now burned through cabazitaxel and they don't have a BRCA mutation for you to give any kind of PARP inhibitor. And they're like, what do? I have no trials for this person, but is an ECOG 1 or 0. And then we bring in the PSMA. So I'm looking at PSMA studies in the later line setting. I hope you got that from my introduction, Michael.
Yes, I did.
Essentially as a salvage therapy. So PSMA, Mike already spoke about it, but prostate-specific membrane antigen is a transmembrane carboxypeptidase that is highly expressed on the surface of prostate cancer, including metastatic lesions. You've also seen it, I think it's in myeloma, it can be expressed, and also renal cancers as well. But let's not go into that. Let's talk about prostate.
It is something that we discovered completely accidentally, though. I will say this whole, PSMA, it also is in other cancers as well.
Oh, no.
Just a point to be aware of for any new players out there.
Yeah. And so there's 2 trials. I'm going to focus on the Vision trial, but there's also the TheraP trial, which I will briefly mention at the end. So the Vision trial, they had a vision, they went for it and they delivered. It was a phase 3 randomized trial. Patients had at least one PSMA PET positive lesion. This was then compared to standard of care. It was lutetium plus standard of care versus standard of care. Standard of care options depended on the prior therapy. And I'm bringing this up because it's actually important. They were eligible for the trial if they'd had one RP plus 1 or 2 standard of care taxane regimens. And the standard of care in the control arm was either an alternative RP, so an RP switch, a bisphosphonate, radiation, denosumab, or glucocorticoids. There was nothing in the context of other chemotherapy. You weren't allowed chemo, essentially. You weren't allowed other radioisotopes. Had to have a good ECOG performance status. Of note, nearly all the patients had already received docetaxel and about 38% had already received cabazitaxel. So it was quite a late line trial. They were randomized to the intervention arm, lutetium, which is given every 6 weeks. And in this case, 4 cycles, and you were able to increase that to 6, depending how you how he went, or standard of care alone. You had CT, MRI, and bone scans. Also interesting because you need a PSMA PET scan, but in I think context of probably this early trial, they probably didn't use it that much because it's also difficult. Of other interesting notes, about a third of the patients had ENZA up front, a third of the patients had ABI up front, about 1.9% had APA, and 0.4% had darolutamide. Now, I suspect that's probably from when things have come onto the market. Then you've got the primary endpoints. There were two, either radiographic progression-free survival or overall survival. So if either of those endpoints were met, you got a thumbs up. The secondary endpoints was objective response rate and control of disease. 87% of patients had PSMA PET positivity, and we saw about a 50%, 6% dropout rate initially in the standard of care arm. Interesting, there's a lot of people not going for standard of care, but you don't really have a lot of options. Glucocorticoids, okay, not really going to do much. There was then more education. There was sort of caps and sort of other nuances that were brought into the trial implementation, and that dropout rate reduced to about 16%. So the radiographic progression-free survival was actually begun afresh at that point in time, I think because there was going to be a lot of biases in the dropout in the standard of care arm. Overall, there were 580 patients in the PFS arm and 831 patients in the OS analysis. So just looking in sort of the collection of patients. So that's just, I think, something of note and of interest and potentially a confounding bias, Michael.
Could I also ask, you mentioned that 80% of patients had PSMA positivity, 87. Apologies if you're going to come to it, but is there any analysis about the patients who didn't? Because I'm just thinking of differences between your study and mine. In upfront PSMA, PSMA positivity was mandated.
Look, it was mandated. I don't know how they got through it unless they were in the standard of care arm.
It's just one of those things.
Let's then move to the results because I feel that's where we should get to, and it should be somewhere in my notes. So the primary endpoint, overall survival, the hazard ratio was 0.62, which was statistically significant, with a median overall survival sort of 15.3 months in the intervention arm versus 11.3 months in the standard of care arm alone, which is better when you've realized you've burned through all your sort of standard of care treatments. If you look at then this sub-analysis, the forest plot, it pretty much all favored that of lutetium, and the radiographic progression-free survival also improved from 3.4 months in the standard of care arm to 8.7 months in the intervention arm with a hazard ratio of 0.40. So much better RPFS and OS data as well. Other interesting points to really bring up is just the breakdown of people's responses to lutetium. I think that's something it's worthwhile noting. So about 9% had a complete response, 41% had a partial response, and another 35% had stable disease. So 75, 80% that had some form of control or better in the intervention arm. And as expected, 3% had a partial response in the standard of care arm, and then the rest was stable or progressive disease. Duration of exposure, much longer in lutetium, 7 versus 2 months approximately. Median cycles, 5 versus 2. And median duration of cycles was sort of 1.38 versus 1.12. So that's kind of what you're looking at. And you're right, as far as adverse events go, Mikey, it was you didn't mention this, but I'm going to say you're right anyway. It was more in the intervention arm versus the standard of care arm, but that also kind of takes into account the fact that standard of care was pretty benign medication. There was no chemotherapy. There was another ARPI, which is usually pretty well tolerated. But we did see quite a bit of bone marrow suppression in the lutetium. Fatigue was double in the lutetium arm. So was dry mouth was 39 times that of the standard of care arm. 40% had that because it also attacks your secretory glands as well, which can be really hard. If you ever wondered what I use to manage it, xylem melts I find quite good. It does cause issues with sort of talking a little bit and some kidney impairment as well.
It's like we're giving these people Sjogren's.
Yeah, a little bit, but it's also Sjogren's versus death. So there are limitations. I think the thing is this is a late line trial. So there was no versus cabazitax, or there was lack of a proper placebo in the control arm. So wasn't double blinded because you can't really double blind a standard of care to an intervention. Well, you probably could, but it's a lot of extra time toxicity. So that would be quite an interesting discussion point. That was kind of the main limitations that I sort of wanted to bring up. It obviously shows that it is work better than standard of care. It's sort of like the kidney cancer stuff when it's versus avelumab versus standard of care, which was nothing. But that's just something to sort of flag. And then you've got the TheraP trial, Michael. And we did cover that a while back. I don't know if you remember, but that was versus cabazitaxel. That was their intervention arm. And overall survival was similar. And there was sort of crossover sort of later down the track with lutetium sort of benefiting where cabazitaxel sort of held out. But as it stands, if you sort of do a really cross-trial comparison, the VISION trial was later, post-RP, post-chemo. The TheraP trial was just post-dosing. The investigational arm was lutetium or lutetium plus standard of care, and the control, which is probably that big thing. The primary endpoint in TheraP was also PSA response. And with the primary endpoint difference showed better in that of VISION, but of course they're sort of looking for different things. And whilst had a favorable progression-free survival, there was no overall survival in cabazitaxel versus the lutetium. But again, I think sometimes it's quite nice when people are sort of over having chemotherapy and they can have something that is overall relatively well tolerated. That's sort of how I would leave this, is that lutetium definitely has a role in that castrate-resistant space. There are still unanswered questions of how to optimize this and when to put it into the scheduling. And I don't think anyone's going to know that for a little bit as we continue to investigate.
Yeah, and we've spoken in previous episodes as well about the emerging lack of treatment options for castration-resistant prostate cancer now that all of the good stuff, all of the hormonal stuff, the novel anti-androgens are being moved into the castration-sensitive spot. So lutetium, once the logistical and access issues are overcome, which there will be, might start playing a bigger role in the castration-resistant space because it has to compete with fewer agents.
Michael, what are we going to do next week?
So Josh, by special request, has put in the agenda for our next episode, and this is a couple of studies looking at biochemical recurrence and how we treat and manage the oligometastatic recurrence of often high-risk prostate cancer. Do we need to assume these patients are castration-resistant and whack them with 10 cycles of docetaxel? Do we need salvage radiotherapy? Those questions probably won't be answered, but we hope that you'll join us next time as we take a sojourn through the solar system and look at a combined analysis of solar and Saturn. You might say we are embarking on a sojourn through the solar system because the other study that Josh will talk about is Embark. So we hope you will enjoy the episode next week and you'll join us, because if you don't enjoy it and you don't join us, Josh will be very sad.
Join us on our voyage.
Thank you so much for listening and for watching. If you've joined us on YouTube, we will see you next week. Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.